Hi everyone, welcome to another one of your MUPPITS lectures, and today we're going to be talking about pediatric endocrinology. So just a heads up that in this lecture I won't be going through all of the conditions in great detail, but there will be a lot of information for you guys to have a look at in your own time on the slides as well. So these are the topics that are in your matrix, and yeah, let's get started. So we're starting with type 1 diabetes. And it's really important that you learn how to identify a first presentation of diabetes. It is quite different to how you get a presentation in adults. So you often get kids presenting with polyuria or bedwetting, polydipsia, so feeling really thirsty. Kids often have weight loss or failure to thrive and fatigue. And a lot of kids do present with DKA as their first presentation. So on that note, ETK is very urgent and can be life-threatening. So you need to look out for things like nausea, vomiting, decreased conscious state, confusion, lethargy, drowsiness, and also the Kussmaul breathing, which is the deep, labored breathing. DKA is also a very common OSCE topic and comes up a lot in exams, so we'll go through a little bit of that in detail. So in any presentation, you want to identify what triggered the DKA this time in order to be able to prevent it the next time. So some triggers can be a first presentation, an illness, or inadequate insulin. So either a missed dose or if the child has a pump, a failure of the pump. And in terms of investigations, you want to do your serum glucose. VBGs are very useful and very fast. So you look at the pH or the bicarb and also presence of ketones in the blood or the urine. The management is also very high yield. So you want to give the patient an IV fluid bolus as quick as possible, usually sodium chloride, and an insulin infusion. Then with the VBG and USCs, you can look at the potassium, and if it's low, you want to supplement that. And also the insulin tends to bring down the blood glucose, and you want to prevent complications from hypoglycemia. So you give dextrose or glucose as an IV bolus if the blood glucose level is less than 4. You also want to keep the patient nil by mouth until their acidosis is reversed. And the reason we care about DKO so much is because there are many complications, but the main one I want to talk about today is cerebral edema. So you want to look out for things like headache, irritability, lethargy, vomiting. And later on, the patient can have decreased consciousness, incontinence, and thermal instability. And you get a change in vitals as well. So bradycardia, hypertension, and respiratory impairment. The way you want to manage this is position the patient with their head up, reduce their fluid infusion rate by 1/3, and also give mannitol. Details about this can also be found in the RCH guidelines, which are very, very good for all conditions, not just diabetes. So I'll highly recommend that you guys go and have a look at that as well. So just in terms of type 1 diabetes in general, your investigations. So at the bedside, you can do your urine dipstick and urinalysis, and you may see ketones and glucose, high glucose. And in terms of the blood, it's important that you know the values and the cutoff ranges. So a random glucose greater than 11, fasting glucose greater than 5.5. HbA1c, although we use it a lot in adults, tends to be less reliable in kids, especially if it's the first presentation. But if you do it, values greater than 6.5% tends to raise alarms. And type 1 diabetes is an antibody-mediated or a autoimmune disease. So you want to look at investigating for GAT antibodies and IA2 antibodies. And your fasting C-peptide helps to differentiate the endogenous versus exogenous insulin. So it tells you the levels of the insulin that is actually produced in the body rather than the insulin that's given from outside the body. And once confirmed that the patient has a diagnosis of type 1 diabetes, you want to have a look at doing testing for other autoimmune diseases because, as you might know, having one autoimmune disease does increase your risk of having another. So looking at things like your celiac screen, thyroid antibodies, and thyroid function tests as well. Okay, so in terms of management, the main course of management is giving insulin. And I won't go through this slide in great detail, but a couple of things that are really important to know is that regardless of how you give your insulin, there is a total daily dose of insulin that is recommended. So this is 1 unit per kilogram per day. And there are different ways of giving insulin. So you can give a AM and PM dose, or you can give multiple daily insulin doses with consideration of how the patient's blood sugars respond to the diet. And also, the patient can have an insulin pump, which is great, but it's quite expensive and a little bit more complicated. But yes, I would do highly recommend that you have a look at this slide as well. Okay, and whether it's in your OSCEs or your exams or in person, it's really important that when a patient receives a diagnosis of type 1 diabetes, that you give adequate education both to the patient, depending on how old they are, and also their parents. So things to really highlight are triggers of hyperglycemia, so incorrect insulin dosing. Give them a list of high GI foods, explain that a sudden decrease in exercise, illness, stress, menstruation can cause high blood sugars, also things like puberty, and alcohol and some drugs. And in terms of hypoglycemia, same thing, incorrect insulin dosing, not having enough food, increasing your level of exercise suddenly, also illness, anxiety, excitement, alcohol, and drugs. And other things to explain, make sure you tell them how to give the insulin, how to do a blood glucose test, which tends to be really scary for kids because your blood is coming out. So make sure they're reassured and they know exactly how to do it. How to keep a blood glucose record book and the importance of doing so, what to do in a hypoglycemic episode, what ketones are, and also give them information about healthy eating for people with diabetes. Just a couple more things. So blood glucose monitoring, make sure the patient has a glucometer, ideally before every meal, to help to dose the insulin, depending on what type of insulin they have. Potentially HbA1c recommended 1 to 3 times a year, and make sure you aim for blood sugar levels of 4 to 8. You do tend to aim a bit higher in preschool kids because they have an increased risk of getting an episode of hypoglycemia. And with any chronic condition, it's really important that the patient has a multidisciplinary team. So a really good GP who's able to coordinate all the different specialists that the patient sees, a diabetic educator, a nutritionist, a pediatrician, and a podiatrist, nephrologist, and ophthalmologist for monitoring for complications of diabetes. Okay, so the next topic we're going to talk about is hypothyroidism. This is quite similar to adults, except it usually tends to be congenital in kids. So the main cause is thyroid dysgenesis. There are many different types, but I'll leave it at that. Also, you can get dyshomogenesis and central hypothyroidism. So those are the congenital causes. And in terms of acquired causes, you can have primary, which is Hashimoto's thyroiditis. So the recognizing a patient with hypothyroidism tends to come up a lot in your exams. So really important that you know that prolonged neonatal jaundice is a pretty big buzzword. And in terms of prolonged, this means that jaundice lasts for more than 14 days. Also, other signs are listed on this slide. So umbilical hernia, hypertonia, poor feeding, decreased activity, having a coarse cry or macroglossia. The patient can be pale, have coarse facial features, hypothermia, bradycardia, poor brain development, and faltering growth. Note that a lot of these are signs because pediatric patients are usually diagnosed at quite a young age. In terms of investigations, you do the Guthrie test, which is the heel prick screening test generally collected at 48 to 72 hours after birth. Testing your thyroid hormone, so TSH, free T4. Plasma bilirubin, because the patient tends to present with jaundice. You also do a thyroid scan and maternal and infant antibodies. Management is pretty similar to adults, so you start with thyroxine. The recommended starting dose is 10 micrograms per kilogram per day. And important that you give this tablet by crushing it and mixing it with some milk and water and using a teaspoon or a syringe to make it more easy to digest for the kids. And don't put it in the bottle full. And also, if the baby vomits after having the medication, you might repeat the dose. Make sure that the parents are counseled and reassured, and that regular follow-up is organized to make sure that the child is growing normally. and they're developing normally, and also repeat the thyroid function test at every visit. And you also consider doing a hearing test if the cause of hypothyroidism is suspected to be dyshormonogenesis. And you tend to do this regularly in the first year of life. Okay, moving on to obesity. So this is defined as greater than 95th, as the weight of the child being greater than 95th percentile. And if it's greater than 85, then they're considered overweight. Just a list of different conditions that can be associated with obesity. Won't go through all of it, but Prader-Willi syndrome and Down syndrome tends to come up quite a lot, and things like hypothyroidism, growth hormone deficiency, and Cushing syndrome. A lot of medications can contribute to obesity. So anti-migraine medications, antihistamines, antiepileptics, and some antipsychotics. And psychiatric conditions, really important to consider depression in young kids, and also psychogenic polyphagia. In terms of assessing obesity, if you find that they're above the 95th centile for their weight, you want to measure their height. So if they have a short stature, so greater than 50th centile, you want to consider endogenous causes like hypothyroidism, Cushing's syndrome. And if they have a tall stature, so greater than 50th centile, it could be normal. They might have overnutrition, which accelerates the height. But you'd still want to investigate for other causes just in case. Okay, so in terms of assessment, you want to calculate the BMI and plot on a chart. Measure the patient's waist circumference, which correlates with cardiovascular disease risk, blood glucose levels, serum lipids, LFTs, do an ultrasound of the liver, thyroid function tests, and investigate for underlying cause if suspected. And you want to take a thorough history, so thorough diet and exercise history of the whole family, not just the child. Look at family psychological factors and screen for complications like depression. So complications of childhood obesity are vast, but important ones to consider is your slipped femoral epiphysis and genu valgarum, yep. And in terms of endocrine, type 2 diabetes, advanced growth, early puberty, and PCOS. You have an increased risk of cardiovascular disease, so hypertension, hyperlipidemia, cor pulmonale, and respiratory disease like OSA. Children can have a high risk of getting fatty liver disease and cholelithiasis, and also really important to consider the psychiatric complications like low self-esteem, low mood, and impaired social interaction. And an important point to highlight is that childhood obesity does track into adulthood, and you get an increased risk of cardiovascular mortality as an adult, regardless of your adult weight, if the child has obesity as a child. Okay, so the next topic is growth hormone deficiency. So I will say that in the slides there are a couple of flow charts for you to revise your hormones, and endocrinology tends to be a lot easier if you know which hormones affect which other hormones and where everything acts. So I've just put a couple of little flow charts in the slides before this, but just in terms of talking about growth hormone deficiency, some causes are having a pituitary adenoma, traumatic brain injury, irradiation, and congenital conditions. And the way this tends to present is in childhood, the most important is short stature. So immature body habitus, mid-face hyperplasia, delayed dentition, and increased subcutaneous fats are also other presentations. In terms of differentials, some other causes could be Turner syndrome and constitutional delay. Constitutional delay tends to be what we look at if the child's parent was also short at the same age, but have grown to be of normal height in adulthood. Okay, in terms of investigations, you want to do your IGF-1 levels, which is typically low, growth hormone stimulation test, which is how you confirm growth hormone deficiency, You can do an MRI brain to investigate the anatomy of the pituitary gland, as well as congenital malformations and trauma. Also need to assess for deficiencies of ACTH, TSH, LH, FSH, and ADH. If you go back to the flowcharts of the hormones, you'll see that this is where these are all hormones produced in the pituitary gland. So if there's deficiencies of growth hormone due to a pituitary problem, you'd want to also rule out problems in other hormones and deficiencies in other hormones. So the way you manage this is growth hormone replacement, which initially promotes short-term catch-up of growth and also enhances long-term linear growth. And you want to look for and treat other deficiencies, as I talked about earlier, and also treat the underlying cause if possible. Okay, so there are different patterns of growth in children, and there is also a slide on neonatal growth that I put earlier as well. But in terms of growth trends, you have your linear and skeletal growth, which is the length, and this tends to be incremental, and then or slow. So there are different ways to assess that, and also the weight, which tends to be dynamic and changes up and down, and if it changes, can change quite rapidly in children. Okay. And in terms of predicted height, sometimes you might be asked to calculate the predicted height of a child. And for patients assigned male at birth, you calculate the average height of both parents and add 7 centimeters. And for patients assigned female at birth, you calculate the average height of both parents and subtract 7 centimeters. And specifically for growth hormone deficiency, you want to consider if the patient's height is less than the 3rd centile, and their weight is either normal or decreased. Okay, next topic is protein energy malnutrition. So this is a group of pathological conditions that come from a deficiency of dietary protein and or total calories. So there are different types, but I won't go into that in detail. You are more than welcome to have a read about it, but essentially it is primary protein energy malnutrition comes from inadequate macronutrient intake, and secondary comes from some other illness affecting the macronutrient content. So changes in appetite, changes in digestion, changes in absorption, metabolism, and the energy to protein demand. Okay, so some primary causes can be depression, fasting, anorexia nervosa, which all impair the amount of macronutrients that the patient may take in. And some secondary causes, so it can be grouped into GI function disorders, wasting disorders, and conditions causing an increase in metabolic demand. So in terms of GI function disorders, you have pancreatic insufficiency, enteritis, enteropathy, and also changes in the lymphatic nutrient transport. Some wasting disorders are AIDS, cancer, COPD, renal failure, and end-stage heart failure. And conditions that increase the metabolic demand are infections, hypothyroidism, pheochromocytoma, burns, trauma, and surgery. So the way this tends to present is weakness, lethargy, sometimes diarrhea, amenorrhea, and loss of libido. And the way this is managed is typically oral rehydration if the patient tolerates. Otherwise, you'd want to consider NG IV nutrition. Careful nutritional rehabilitation to avoid refeeding syndrome. For secondary primary protein energy malnutrition, you want to treat the underlying condition and also tend to avoid lactose, for example, if the patient has persistent diarrhea. Some complications include refeeding syndrome, impaired consciousness, electrolyte deficiencies, heart failure, hypothermia, chronic malabsorption, pancreatic insufficiency, and also mild intellectual disability. So as you may know, nutrition plays a really important part in the development of children as they grow up. So it tends to affect all different sorts of body systems. Okay, next topic is vitamin deficiencies. Now, there are a lot of vitamins and minerals out there, but I've just bolded the ones that tend to come up more often and put some information about some other ones as well for your own reference. And you're more than welcome to have a read of all the other ones in your spare time. So, first important one is vitamin B1, which we also see in adult medicine as well when you look at patients with alcohol-related disorders. So, important consequences to look out for are beriberi, cardiac failure, Wernicke's, and Korsakoff's. Vitamin B12 is also really important and comes up a lot in hematology. So, this is because it's responsible for red blood cell maturation. And an important point is that vitamin B12 tends to be found only in animal protein sources. So for patients who have a vegan diet, they tend to be at a higher risk of getting vitamin B12 deficiency, where you would recommend supplements. So consequences include megaloblastic anemia, growth, movement, developmental problems. And you want to do a FBE or a blood film to check this, and also a serum folate. Next, you have vitamin C, which is important for collagen synthesis and absorption of iron and folate, and tends to be found in citrus fruits. So consequences of vitamin C deficiency include scurvy and poor wound healing. And next is vitamin D, which we've all heard a lot about, I'm sure. It is essential for absorption of calcium from the gastrointestinal tract, as well as bone growth. It tends to be found mostly from sunlight and breast milk. And the consequences of having vitamin D deficiency include hypocalcemia, hypophosphatemia, and rickets as a result, and also secondary hyperparathyroidism. There are many different investigations you will need to do to investigate this. So serum calcium, parathyroid hormone, and x-rays of the bones. And in terms of risk factors, so maternal low sun exposure is an important risk factor. And also if the infant is breastfed but not exposed to sunlight, children with diet low in calcium and vitamin D, and excessive strontium intake. You, of course, have your vitamin K, which is important for clotting, and some other minerals that are important are iron, which cause iron deficiency anemia, which is a microcytic anemia. You've got your calcium, which a deficiency can cause rickets. Iodine, an iodine deficiency can cause hypothyroidism or a goiter, and zinc, a deficiency of which can cause growth failure, impaired immune function. Okay, and I believe this is our last topic for the day. So ambiguous genitalia. The most common cause is congenital adrenal hyperplasia. So I will go through that, but I do have a list of other causes later on as well. Now, in terms of ambiguous genitalia, it is a spectrum of conditions which involve deficiency of enzymes in the mineralocorticoid, glucocorticoid, and androgen pathways, and it is an autosomal recessive disorder. So in terms of pathophysiology, the most important thing to note is that the most common deficiency is 21 alpha hydroxylase deficiency, which is a pretty big buzzword. And the ambiguous genitalia congenital adrenal hyperplasia is essentially an impaired production of glucocorticoids and mineralocorticoids, which then puts all the hormone pathways towards producing more sex steroid hormones. So here we've got a diagram of the different parts of the adrenal gland, which would be important for you to revisit. And also a bit of a pathway in terms of how the hormones work and where 21 alpha hydroxylase fits in. Okay, in terms of presentation, so when patients have excess androgens, it presents differently in patients assigned female and assigned male at birth. So in patients assigned female at birth, they tend to present with ambiguous external genitalia. So this could be virilization of the external genitalia, a clitoris that's larger than normal size, urethra, and a vagina, which may be fused. Patients also have early puberty, rapid growth, but reduced stature, hirsutism, and acne. In patients assigned male at birth, they may have an enlarged penis and a pigmented scrotum. Now, in terms of aldosterone deficiency, this can cause a salt wasting condition. So you have low sodium and high potassium. This can ultimately lead to an adrenal crisis, which you can see by circulatory collapse due to dehydration, hypovolemia, and hypotension. Now, this is a really important condition that we need to look out for and address as soon as it is recognized. In terms of cortisol deficiency, you have hypoglycemia, the baby can be floppy, weight loss in the child, and vomiting as well. Okay, to investigate this congenital adrenal hyperplasia, in patients assigned female at birth is generally detected at birth, but this is not always the case for patients assigned male at birth. And they tend to present, unfortunately, with a salt-losing adrenal crisis first. To diagnose this condition, you look for the levels of 17-alpha hydroxyprogesterone. You can do this in the urine, and these levels tend to be raised. If a pituitary problem is suspected, such as the pituitary not producing enough ACTH, an ACTH stimulation test or a synactin test can also be done. To manage, so in the immediate setting, when you have a patient presenting with salt-losing adrenal crisis, you want to give IV hydrocortisone as soon as possible, also sodium chloride and dextrose IV to correct the hypovolemia. And for lifelong management of these patients, you want to give hydrocortisone, which is a glucocorticoid, and fludrocortisone, which is a mineralocorticoid. And the glucocorticoids are given to suppress the ACTH production, and mineralocorticoids are given if the patient is having a salt-losing crisis. Now, to monitor the progression of congenital adrenal hyperplasia, you want to monitor the patient's growth and plot it on a chart. Also, skeletal maturity with things like X-rays. Plasma androgens and 17-alpha hydroxyprogesterone levels should also be regularly monitored. Okay, and that's all the topics we have for today. Please feel free to email me at my email on the screen or send me a Facebook message. My name should just be Lakshmi Veerasekara. And please make sure you go back and have a look at the slides. And there have been a couple of slides that were skipped for the purposes of the duration of the presentation, but there's some extra diagrams for your background knowledge and also some extra information about other causes of conditions and things like that. So please make sure you have a look at that, and good luck with your revision. And once again, let me know if you have any questions. Thank you.